Hi, Michelle. It's so good to see you again. This is
So good
just
to
so
see you.
exciting. Yeah, I'm excited. I almost just want to jump in and just take the bull by the horns. There's just so much I want to talk to you about. But can you, for the viewers' viewpoint, introduce yourself? How long have you been a physical therapist? How long have you worked in management? All of that.
Yeah, so my name is Michelle Figueira. I have been a physical therapist for about 18 years now, about 15 of those years primarily in the acute care setting, and transitioned into leadership about 5 years ago. Prior to that, my passion always was in the ICU, specific trauma. If you want to get me like super excited, let's talk a little trauma PT, and I'm like all in. So transition though into leadership, I found another passion. I love therapy, but I also loved getting to know people, and really most importantly figuring out how I can support the therapist and cultivate their growth. So that has transitioned me most recently into a different area of practice, which is inpatient rehab. So that's kind of my snippet of a career.
No, it's exciting. We met last year, and I realized I never asked you that. I never actually asked in depth, like, what was your trajectory of getting into leadership and on the management side. I really was interested in a lot of questions I get. I get so many questions from a lot of women's health therapists. That's where my background is.
Yeah.
And they'll ask, as a women's health therapist, outpatient practicing, pelvic health therapist, if I wanted to serve the inpatient population, women after birth, right? What do
Mhm.
I have to do? What do I need to know? And now that I actually have, right, someone who's been in acute care, passion is trauma, you've been a manager, you've kind of, seen a lot of opportunities come up for people to start programs. What would you say to that individual for them to be successful in the hospital if they wanted to actually leave outpatient and start working with women in the hospital after birth?
Well, first I'd say, what an amazing time. I mean, this is it, and I think as more people become aware of the statistics and the data, of where we sit right now with maternal mortality and the trajectory that we're on, it's really starting to get a lot of traction. So I think there's so much opportunity. And I would say, honestly, kind of doing your own little investigation, deep dive into it. That way you're kind of arming yourself. You have control over the knowledge that you possess. So getting yourself really bathed into, what that facility offers, and really starting to network. I think that's a huge opportunity in networking and developing those relationships, and beginning to peel away, where your niche might fit into. So I think there's so much opportunity out there. And there's no right way too. There's no one right way. There's many ways. And I think sometimes we get very fixated on, this is what I need to do, and I just missed the boat of it. No, no, no. There's a million. And sometimes it's just starting a conversation. Some of the greatest barriers removed were, for me, interacting with people that I didn't really even know had the ability to help and really, tap into their interest. And, so I think there's a ton of different ways in which you can do it. But, starting with the knowledge part is probably the best way to start.
Over the last 18 years, have you had therapists, and even just stepping back away from like maternal health, definitely an area for growth, but just in general, have you had therapists who had an idea of like someone or a population or some new method that they wanted to bring into acute care and just say, hey, Michelle, you have a minute?
Yeah, I think, as I look back on my career, first, I think therapists are some of the smartest people, and we don't give ourselves enough credit. Like our critical thinking skills are just phenomenal. As I look back, I see so many therapists who had phenomenal ideas, that really could peel away and serve the patient population. And I think a lot of times, getting that evidence-based practice out there, and really continuing to immerse yourself in the continued learning, really allows you to be able to have that ability to speak to the therapist, speak to your leadership, and then be able to kind of peel that away and be able to then, get that program started or begin that discussion. If nothing else, begin the discussion of what that means, what it looks like, and what does it take to get that going. We have implemented some different areas within the acute care setting. When I was a leader, we developed our NICU, and we also, by discipline, I'm physical therapy, but we really took our speech therapy services and just ran with fees. And we're able to unpack a program across the system for our patients, and really giving our therapists the ability to be trained and practice at the top of their license, so that our patients are getting the best quality care, no matter if they went to the hospital that's up here or the hospital that's 300 miles away. But I think that it all kind of begins with your personal desire to grow and to, tap into the education and never allow yourself to get stagnant.
Did you ever have to kind of nudge a therapist along who was a little on the shy side, didn't really want to speak up? You knew they had talent. They could probably teach and lead their teammates, but you had to nudge them a little bit.
Yes, quite a bit. I think of some of my folks that I'm most proud of. They did not volunteer for any of this at all.
So they were voluntold.
They were voluntold, and they'll be the first to tell you that. I didn't exactly have the choice, but I think that when you see something in people that just sets them apart, and that's their passion, and the only thing that's stopping them from going forward is themselves. To me, that's the most. I take that as the highest challenge, because I want to help people. I want to help our patients, and I know what they have inside of them. And if I can get to that person, think of the cascade effect we all could have. I think of one in particular with postpartum. She's the one that brought this to me, and incredibly talented, so smart. But she needed some confidence, like we all do at times. We all need somebody to say, hey, you know what, you're doing a really great job. I'm going to give you some support. I'm going to give you some resources, and at times to develop the trust. And know when to say you're going to push baby bird out of the nest. Like, it's time to go and, fly and soar, and just allow yourself to just lean into that uncomfortable ability. I don't know how many times I've said that this week too. And so I think that is, as a leader, it's so satisfying to see people develop, mature, grow, and come into their own. It's one of the biggest joys that I have.
And so this particular person, I really want to kind of get into the avatar for that therapist that you're talking about, because there is an avatar. There's talent in our field. I feel like it's just so undervalued, and we don't even. I don't know if it's a fear, but even when it's coming to our senses and going straight to the physician rather than the nurse, it's little things like that, on a basic level. Are we really taking opportunities to really show our value on the team, or are we just kind of putting it on a note and sliding it under the door? And so with that individual, I know that there was a transitional period of where, here's an idea that I have. I'm going to present it to physicians, but then now I'm going to teach my colleagues. There's a big jump from one to the other, right? When you get enough confidence to actually teach your colleagues, right? What do you have to do as a leader to facilitate that?
I think know your person really well. Take the time to know them, not as a therapist, but as a person, and begin to know where their vulnerabilities are, and be able to support that then. I think trust is huge too. Trust that I'm putting you in this position for a reason. And this is the why behind it, and just kind of, support you through it. But I think, it's a bit of a balance sometimes, because you don't want to. I think a lot of times we just get so caught up in, well, let me just tell you what to do, and I'm going to be breathing down your neck. But it takes a lot of I don't know, I guess like restraint in a sense too, as a leader, to be able to separate yourself and allow yourself to, kind of like with your children sometimes, where you need to let them fail sometimes, not to the point where it's a safety, but just let them figure it out. Because we all had to do it at some point. And sometimes that's when our most valuable lessons come, is by allowing people to kind of figure things out and not just jump in and say, well, let me fix this for you. I am 100% also guilty of this. It took me a while to get to the point where I'm just going to be like, okay, we'll let you kind of do, I'm going to give you some resources. I'll jump in when I feel like it's necessary, but let yourself kind of figure it out. So I think it's a bit of a balance sometimes. And
I love that.
And it's a practice too. It's not something you're going to perfect. You're going to get it wrong sometimes.
Excellent. And so this particular therapist, there was an award that was won. Can you tell me a little bit about that? We talked a little bit off of line, but give me a sense of how big of a deal this was at your
Yes.
hospital.
Yeah, this was huge. And it was a regional award, a healthcare council, and it's escaping me the last bit of it, but it's a very prestigious award that only one person out of your hospital gets awarded this. And so how this all kind of came about was, Sunflower Award is our highest honor for therapy to be nominated. And this therapist, I nominated her for our Sunflower Award. And our hospital president actually was present for the ceremony that I put on. And I read the letter, and he was so moved by it, like literally almost to tears, that he came to me and said, I need you to nominate her. She deserves it. Do you mind? And of course, I'm like, yeah, of course. Yes, let's do this. Because she deserves it. She had the courage to ask why. So she was one represented again amongst many different hospitals, Johns Hopkins, many hospitals within the Northern Virginia region up here. And it was a great honor. It was really, and so well deserved. She put a tremendous amount of work into it.
Now, Michelle, what was the award for?
It was an employee of the year, basically representing a healthcare worker who's going above and beyond. I mean, far above where their job basics lie, and really making a difference in the patient's lives. So there was a bunch of criteria that kind of went along with it, but really that's kind of encapsulated it, is just somebody who is just exemplary at what they do.
Oh, that's wonderful. And then you guys said that it had something to do with starting a program that, where women were able to get occupational therapy services or both therapy services as well after C-section. Is that right?
Yes. So do you want me to talk a little bit about?
Yeah, I would love that. Absolutely. Unpack that for me.
Yeah, no, it was a crazy situation where this therapist came to me one day out of the blue, and she's our NICU therapist. And there was twins on the caseload. And she said, Michelle, I just experienced something. I want to run it by you. I said, what's up? And so she told me that she was treating the twins, and the mom who gave birth came in to visit. And she said, Mom was looking rough, like really struggling with walking, and just looked like in pain. And so she had asked the mom, like, how are you doing? And the mom was like, doing terrible. I can't get dressed. I can't go to the bathroom. I can't get up on my own. And she's like, as soon as you could, she's talking through this, the anxiety is coming up. And she's like, I don't know how I'm going to care for these twins when I go home. I can't care for myself. And she asked a very simple but very moving question. Why are we not involved with these patients? And I distinctly remember sitting back going, well, I don't know. Why aren't we involved with these patients? Mom just had a major abdominal surgery, one of which I had twice. Like, yeah, why didn't I have therapy? It doesn't make a lot of sense. So I said, well, let's do something about this. Let's walk through this. Can you go back and talk to the nurses on the unit? Get a feel for what they're offering. Are they giving any type of transfer training or, biomechanics? And let's do a deep dive in the research. Let's take a peek at it. So I tasked her and one other colleague with that. And when they brought back to me what they had found, it blew me away. It really blew me away to the point where I was like, well, this is definitely an area of opportunity. And we need to move this forward. So on the heels of that, we prepared a presentation to our executive leaders in the rehab service line, and they agreed as well. I mean, the light bulbs were all going off as we were unpacking this to them and rolling it out, and really creating this story that we're all kind of living, but we're all missing too.
Yeah.
It was
Which
really,
I want to unpack that. I want to unpack that a little bit, because when you say like get into the research, I'm dealing with that now. Like I'm like, what research? Like we actually had, fortunately, the abdominal surgery protocols that were actually built on gallbladder surgery and hernia repair, more or less hernia repair, I should say. Other surgeries have been included, but it was primarily hernia repair, and it was about 22 professionals over 5 institutions. Vanderbilt was one of them. But that's what we had to use, because they had one tiny section in the patient education, the handouts, where it was talking about body mechanics with lifting a baby. But that's what we had to use in terms of the research to support, at that time it was physical therapy and not occupational therapy, but physical therapy services after C-section. That's all. We were just pulling from the research we had about abdominal surgery protocols, right? And so when you guys said, you went into the research to present to your executive team, was it the research at your hospital, just knowing that moms were not being seen by even nurses? They weren't really given instructions. Was that part of your research pool?
Yeah. To your point, there definitely isn't that much out there. But even pulling from the threads of the pelvic floor and some of the literature that was out there, tying in the trends of maternal mortality and some of the up and coming things in that nature. There was just enough, I'll be honest with you, maybe I word it this way. There was just enough to know that there's something here. But it certainly wasn't something that, you could pull from 5 articles published last year on X, Y, and Z specific to this. It was just like one of those things where it's like, interesting. And yeah, there was nothing that was very specific. You were kind of pulling a little bit from here, this article, a little bit from here, but you could definitely tell, when you looked at it from the standpoint of, we're working with patients that have not had any surgery, that just come in with shortness of breath. And we do not think twice about it. We're like, yep, let's do some energy conservation and we can serve this patient, no problem. But then when you frame it in the standpoint of, it's such a major abdominal surgery that, we do X-lapse. And again, but we're missing this, there were so many different ways to phrase the conversation and to present it that it was a really interesting and amazing opportunity to have.
Okay, so I want to hit this at from a lot of different angles, because I've spoken to therapists, right, who have been like, okay, how do I even approach my rehab manager about this? So this person went to you after encountering a patient who had twins. Those twins were in the NICU. She's the NICU therapist, and I don't even know kind of like the hoops she had to just jump through to figure out how she could also address this caregiver needs. I know that NICU therapists can do that, but it's not like an easy, seamless, I'm going to treat you too, even though I'm the NICU therapist for your babies. So she did that, but the way she approached you was not, I have this idea, I have the literature. She was just asking why. Now, for the therapists who are in a hospital in this situation where it's like, okay, we don't have the resources, we're hardly, getting everyone seen in our current census. What would you say before you go back into the executive team meeting that you had and the pitch that you made to them? What would you say to those therapists who approach a manager with that? Manager says, we can't see this whole big patient population that you want to see. We're not even hitting the people that we have to, that are on our caseload.
Well, I have a lot of thoughts on this. There's lots of thoughts. I think persistence, and it's the thing that comes to my mind. And we're all doing this for the patient. And yes, we can create barriers upon barriers upon barriers. We're good at that at times. But I think when you bring a conversation regarding patient care, I think whenever we really are looking at um, always continuing to make ourselves relevant, always trying to be innovative, figuring out, as medicine develops, as our research develops, how are we going to be kind of on that cutting edge? You can never go wrong with phrasing it patient centric. Can't go wrong. I think part of it is also figuring out just the language of your leader. I think that that's important. You can't ignore that. You can't go in like, bull in a china closet, like, I wanted to, you might not get the result you want. You totally can, but you have to think about what is the result that I want to get, and I think understanding that sometimes just opening that conversation, understanding that people sometimes they need a minute to sit in it. And that's really hard. That's so hard, especially when you're being vulnerable, you're bringing something up, you feel passionate about it. You've done enough research to kind of be able to talk the talk to your leader. Of course, you want them to drink your Kool-Aid, come on, get on board with me. I'm so excited about this. But, I think going into it so that you're not disappointed, just have good expectations, and then just round back with them and say, I understand that, this is a lot that I'm giving you. Can we please set up some time next week, whenever it works for you, to be able to revisit this conversation? I would really love to continue it. That way you're not, you're allowing that ability to take the pressure off of your leader, and know that they have some time too, so
Okay,
that would be my suggestion.
that's really great advice. So learn the language of your leader.
Mm-hmm. Yeah.
So that takes time,
Yes.
right?
Yeah.
This is not usually, I mean, for this particular therapist that we're talking about, she obviously had time, and in relationship that she had developed with you. How likely is it for someone who's fairly new into an acute care setting like myself? And I've even told this story. I'm trying to get a program started as fast as possible. Probably not going to happen in my first 6 weeks.
Mm-hmm.
Probably not even my first 12 weeks. I haven't actually built that rapport, right, to
Yep.
learn the language of my leader. And so what would you give that person who's like eager like me? If I take a job right now, I know in 3 months I'd want a program started because I have so much. I have like so many ideas. I already know like what I would want to do. What do you tell a bull like me in a china shop?
Mm-hmm. Well, yeah, you're talking to one too here. Total honesty on that one. I think that it's hard for us to work through the process and go live in 8 hospitals. It took a long time, and I'm not ashamed to say, but it took over a year and a half from start to implementation. And there's things that you learn along the way that you will never learn unless you go through it and you walk through it. And I think that's sometimes like it's a double-edged sword. It's so cool because it exposes you to so much. It is going to really benefit you in the future. But in that moment in time, of course, it's like there's moms giving birth tomorrow. Let's go. Let's do it. But I think, being patient, understanding the process, putting a plan in place. To me, plans work great. You might have to pivot 15 times, but if there's a plan in place, everybody knows what the focus is, and we're all kind of rowing in the same direction to accomplish the goal. And I think the other side of it that was really helpful for me is having a support system. Whether it's somebody in the field directly, who's working side by side with you at a different hospital doing the postpartum, navigating that, or just somebody else who has done it in something, in a totally different, discipline, but really being able to have somebody that you're able to lean into when you feel those frustrations, and then to give you guidance, give you some feedback, maybe you can try this, maybe you can try that. I think those are 2 really helpful, tools that you can use.
Okay. So let's go back to your hospital. Executive leadership. Was this therapist with you, or did you feel like you needed to to at first present it to your executive team as the manager who wanted to implement these services and wanted to use your staff? How did that go?
Well, I used the tactic of like a surprise attack, basically. I adore my
I was like wondering, I was like, why the pause? What is she about to say?
I know. Well, and it's funny because I brought the two therapists in because I'm somebody that I like to stand in the background. I want the people who had the idea, I want them to shine. None of this would have happened without them. So they need to be there and really take credit. And so I ended up I did let my immediate supervisor know, hey, I have a little something I want to talk to y'all about. No pressure, no nothing. But they weren't exactly expecting the PowerPoint presentation that we had put together. And they loved it. They absolutely loved it and were impressed. It worked well. Now, maybe some people that wouldn't work as well, and you would know who you can and cannot do that with. But I really I tend to find that going into things, giving enough information, but not too much, really allows people to come in with no bias, fresh minds, really paying attention to what you're saying. I find it to be, I don't know if it's more positive. I'd have to survey them, but I feel like it really allows you to bring in your audience, to drill the message of what you want to have put out there.
Okay, Michelle, I need specifics. This is just how my mind works. Because I don't think I actually knew that you went in with a PowerPoint to your executive.
Oh, yeah.
For some reason, I was thinking like all the steps that I've taken, it was only just planting seeds. Like I couldn't really prepare anything because it was like, let's see how this person feels about this. Let's see how this department works. So you had gotten all of this information before you did the PowerPoint. Is that right? Like you had asked what the process was for taking care of moms on the NICU. If it was a mom after a C-section, you had already done your due diligence, at least your therapist, to figure out, okay, they're not getting care here. You had done your due diligence on other units to figure out, okay, they're not getting care here. And so that was what you gathered together, and then research. You know, you had gotten the research that you needed, the maternal mortality, morbidity statistics, all of that to create your PowerPoint. How long was that process of getting all of those pieces before you even approached your executive team? How long would you say that process was?
I feel like that process was probably one of the more short time spans because we were all operating very much in this very eager, excited state. And it helped that we knew our executive team was coming up on a set date, and there wasn't that much time. So we're like, all right, let's go. We got to get it together and we got to make it look great. So we really were able to, and I think sometimes that's helpful too. You know, there's a defined time, we got to get it together, and let's go with that. But yeah, really just kind of, looking back now with all the data I have, I'm like, oh, we could have done this and this and this. But at the time, that's what we had. And it really delved into even just the services that our hospital system provided. I was shocked that on our postpartum website, it actually talked about occupational therapy and physical therapy as a service offered. Now, full transparency, I think it was more in the respects of like as an outpatient, but that's not what it said. That's not what it said. So I of course, I'm snipping that. I'm like putting that in there, and just trying to think of every possible way that I can pull in information to really paint a beautiful picture of this.
You used your hospital's own like testimonial against.
I sure did.
This is classic. I'm serious. This is so classic. This is gold for anyone. I'm telling you, you're like coming in the middle, like rewind, because this is true gold. Okay, so you had a PowerPoint. Your executive team is just like, okay, Michelle just wants to talk, present something, an idea, but they don't really know what, right? Mm-hmm. Yeah. And so you're giving all of this information, the data, the statistics, the vision that your hospital has for serving this population. And then like, what is the pitch? Like, what's the ask of them? Do you remember what exactly that was?
Yeah, very distinctly. One other point that we did now is a very loose compared to what we know now with the skills that you've taught the therapists. But really, what is it that we would do? We included that in there so that they had an idea that this would be fairly traditional, but there would be some differences for sure with what we could offer as support. But we really went at it as, if you can tell me why we should not be working with this patient population, that's really flipping it on its head, and wording it in that capacity. Right now we don't pick and choose who we evaluate and who we treat. We don't, and we should. That's an ethical thing. This should be no different, and that's where I do get on a little bit of a soapbox whenever I hear like resources, and it's real. It is 100% real. We're very limited. There's just not enough of us. But that doesn't mean that we just say no. We have to be creative. We have to figure out solutions, and we got to work together. There's a lot of us out here and really smart people. Just because we can't figure it out in this moment doesn't mean that somebody hasn't figured it out, 100, 200, 300 miles away, really figuring out how to research or reach out and foster those connections so that, you can figure out how it's going to work for you.
Yeah. I have to actually say this to you. So we just presented at CSM with a therapist that we had worked with in our hospital in Colorado. And she moved, 100, 200 miles away to a new hospital, and basically was told that if you can like provide the evidence for why you want to provide physical therapy to this population after C-section, we only want high quality evidence. If you can't provide that, we're likely going to say no. And so like your first portion of that just kind of struck a chord with me. You said that that's not ethical if we don't have to provide evidence for why we're seeing patient populations across the board. I use a lot of the examples like you did, someone who has shortness of breath or someone who has something that we can use the impact 6 clicks on, or some type of outcome measure in the acute care environment. When we have that evidence after doing an evaluation, we make a plan of care. We actually say this person would benefit from so many days of physical therapy for so much time, right? Or occupational therapy. But to not even do an evaluation after someone who's had a major abdominal surgery to get that evidence. And it's like, what exactly do they need? Do they need articles? Like, what high quality evidence is more high quality than doing an evaluation of that person to see if there would be any benefit of your services? That's kind of where I was thinking, but I wanted to hear it from you. Like, for this particular person, what would you tell her?
Yeah, I think it's very difficult. For me, my first thing goes, I wonder like the why behind it. Like, I feel like you got to get under, like in the underbelly of it, and maybe have developed a relationship and have that conversation with them, see where their headspace is. Are they able to give you, what are they able to tell you about, for instance, the patient that's short of breath, or I think of sometimes, might get yelled at with this, but like the total joints, that they're going to be fine. They don't need, but we're consulted all the time. And I think that I'm grateful I didn't run into necessarily that barrier. So I have a lot of empathy. But I think that just continuing to engage in that conversation and being persistent, but respectful, and listening, because there's something there. And I think that that's sometimes the hardest part, is trying to figure out maybe what isn't being said as the barrier, and then be able to lean into that a little bit. There's not a real, it's hard. You want to be able to just fix it and just be like, listen. But I think sometimes people, they take a little bit more time. And sometimes too, their feedback to you is going to allow you to take it away and maybe sit on what they're saying and say, okay, well, if that's it, well, let me think about it this way. And then again, just continue to advocate, because at the end of the day, you got to put your head on the pillow at night and know that you are trying to do the right thing. And no one can ever fault you for that. No one should ever fault you for that. And lean into your support systems. I hope that's helpful.
This is super helpful. We have a question from the comments that people are writing in. So thank you. Pooja Bashi wrote, how would you convince an OBGYN to provide these services who works at the hospital but are contracted? And I almost think that, and Pooja, you might have to help us out here with another comment. I almost think she's asking about those OBGYNs that may be not in charge of kind of the way things work. A lot of us put a lot of responsibility on the OBGYNs to say yes, when it's more of it may be more of a rehab department, type thing. It may actually be, do we have the resources or the staff to fulfill these orders? Because I don't really always see that it's all the OBGYN providers that are saying no. Sometimes if they even get a whiff that you're going to be providing services that are going to help their outcomes, floodgates can open really, really fast. And now we've shot ourselves in the foot. So for your hospital, did you find that there was resistance more because of the staffing issue or more because of the providers not really understanding what you would be doing?
So we had two different experiences with that. Our physicians were all contracted as well. They weren't part of our hospital system. They weren't employees of that. What I found, there was two different situations that occurred. If you were able to get ahead of it and present it to the physicians and really be able to talk to the statistics and how your services were going to complement the wonderful work they're already doing, and really help the nursing staff as well, to alleviate them with some of their duties that really it's not in their wheelhouse, biomechanics and all of that, can they absolutely, but that really is owned by us. We're the professionals that own that one. So wording it that way, you're exactly right. They were so excited. The one group was like, well, get ready because the orders are coming. You're going to be so busy. And we're like, wonderful. What I found on the other side of that is if you didn't get ahead of it and you really pass the information of what you would be doing through anything other than a face-to-face interaction where they can ask you questions, where you could control the tempo of the discussion and unpack it the way that it really needs to be. They took it personal. They did find that, well, I'm already doing a great job. Why do I need you? And so for me, it was a lesson learned to really pass that information along, that really you need to be ahead of it. You need to put in that face-to-face interaction, develop that relationship from the beginning, because it's going to solve a lot of problems that may occur down the line if you don't do that, and the resistance that you're gonna potentially encounter.
When you say face-to-face interaction, you just made me think of a nurse that I had that interaction with, and it was like, oh, I could have said that so much better. I am not trying to do your job. This is not saying that you're not doing a great job. You are. But you're so right. That face-to-face interaction, does that involve even just observing and just being on the unit and just kind of being a fly on the wall and just understanding or learning the culture? What does that look like? What do you mean by that?
Yeah, I think all of the above. I think the luxury of knowing, one, in a formal setting, yes, they have monthly department meetings that you can, ask to be part of. But also, I think it's almost even more important to be that consistent presence on the unit and really be able to develop a relationship. Because, in a world where we're always texting and we're all, there's so many different ways in which we communicate that does not involve good old fashioned, hi, how are you? Looking somebody in the eye. You really don't realize how meaningful it is. And I think seeing people, we all want to be seen as individuals. And your peers and colleagues on that unit that you're going to be working with so closely, especially when you're starting a program and you need their support. You need them to be on your side and to advocate, to message to the patient, to be able to get that excitement, because it is exciting. You know, you really need to put in a little bit of the work on the front end, and begin to develop that. So kind of all of the above. You can't go wrong.
All right. Michelle, last but not least, I would love to talk about money. Right. Right now, I'm actually enrolled in a program that's pushing me past my comfort zone. And I had a heart to heart with my business advisor. It's a business program through Goldman Sachs. And I was one of 150 businesses, Black women-owned businesses in the country that was chosen for this program. And my business advisor, we were going through kind of my pitch. And she wants me to pitch to hospitals. But as she's reading it, she had cesarean sections herself. And she's like, I know I'm supposed to tell you this, but I'm having a hard time with it because I know that moms still won't get the care that they need. If you can't get the hospitals to kind of agree from a financial standpoint, you have to prove that you're going to benefit the hospital financially by offering to provide physical or occupational therapy services to moms after birth. And like when we were talking about it, it's like, how do I do that? Like, what does that look like? We have to talk about money in terms of these hospital pitches. And so from an insider standpoint, can you give us just a little bit of just like let's just peel back the layers. What does that look like when we're thinking about money and where is it going? When patients get billed, is the department taking away from the pool of money that physicians would otherwise be reimbursed? Can we have a real conversation about that?
Yeah, and it is as well. It's an area of definitely a little uncomfortable and not knowing, all of the intricacies of it. That was some of the feedback that we received from the physician groups. Is the patient getting the bill? How is this working? Walk me through that a little bit more. And, I think coming for me, I had the luxury of not being pressed as much as others have before me in this area. But I think being able to really try to figure out as much as you can and tap into the people that are around you that are living in that world and figuring it out. Like, what would work for you? How would this message translate? Even though I know that, new procedures and whatnot bring in people, and that's a way that certainly, oh well, we're offering this and we're offering that. This is a little bit of a different area where physical and occupational therapy. Well, what do you mean by that? I think the thing to kind of keep in your pocket with this is trying to continually work through the conversations. One, I think that there's opportunities for us to be able to be proud of this and market this. I think that that's an opportunity where for my healthcare system, we're really working right now on getting the word out so that moms know we're the place to go because you are going to get this service. I think from the hospital side, yes, it's going to cost them money for us in like the labor idea of it, paying us as therapists to go in there. But really you're looking at it pretty high level, and it's a snippet in the bucket, especially when you begin to look at the length of stay that you could impact. That's all data that's collected already. You're not getting anything, so it wouldn't be terribly difficult to be able to do some studies in that respect, to be able to determine readmissions as well. Those are huge hits. Those are two buzzwords in hospitals: readmissions and length of stay. You'll get people's attention with it. maybe more than you want. You'll get questions that you don't know the answers to, and that's okay too. But I think, especially for us as therapists, this is a really tough conversation to walk through, and you're going to misstep sometimes, but you're constantly trying to learn. And to your point, I don't, I, in my mind, still try to figure out what is the best way to walk through this. Where is it that I'm not looking to give me some information, so that people can have that as a resource to go to these conversations, these very difficult ones. I hope, did that help a little bit?
Yeah, absolutely. From an outside perspective, here's the two people that I'm kind of like focused on, and I'm one of them. So the therapist, we talked about that therapist who works in the hospital, who has the luxury at this point of building a relationship, one with you, right? The manager, one with the team, the birth team that's already there, the physicians, the nurses, even the pediatricians, even the NICU nurses. They have the luxury, they're in the system. That other person like me, though, is outside of the system.
Yeah.
How do I, as an outside provider or an outside maybe women's health therapist who wants to really fill the gap between that person coming home, leaving the hospital, and making sure they don't go back, right? And they're not readmitted. How do they start a program in a hospital they don't work for? I was told last week, well, Rebecca, it looks like you might have to work for a hospital to get the data that you need. And I'm not opposed to that. It just felt like I was taking a few steps back, like, so I have to work at the one hospital and then get the data I need and then spread it to another hospital. I thought I did that already, right?
Yeah.
But obviously we don't have the data. So to kind of wrap us and bring us full circle, I want to talk about that person who's on the outside. What would be the best way to approach it from like my standpoint?
Yeah, I think, oh gosh,
Yeah.
that's a really tough one, because I think that, anytime I hit a barrier, I'm always constantly thinking there's something I'm missing. There's somewhere else. What are the other options? Lay them all out on the table, and I think that first and foremost, don't give up. That's it. Do not give up. There will be a way to get it to work, and it may not be the way you thought it would, and that's okay. That's okay. But I think that constantly examining, your connections, I think a lot of times there's a lot of assumptions as well, that, well, it's this or that, but really try to go to as many direct sources to figure out how you can press into that. And just be persistent. Just be super persistent.
So be persistent. I have a hospital right now who doesn't have the staff, doesn't have the resources, but this person really wants to get a program started on that unit. Be persistent. Ask to shadow, maybe. Ask to even one day a week, if you can just observe on that unit and maybe slowly divide your time. Would you just say it comes right down to persistence? Is that right?
Yeah, I think persistence and just staying focused. Don't give up, and realizing too, you're not in this alone. And as long as you keep that heart to you and don't allow yourself to be, your excitement and your passion to be kind of squelched down, I think that it will happen. It's just gonna, it may look a little different, and it may take a different path, for sure. But I think reaching out to people, as many people as you can, get as many resources, continue to talk to the communities that are out there that are doing it, and really find your own path. And maybe that path isn't there. Unfortunately, sometimes you have to really just accept it for what it is at times, and say, well, you know what, this is what I need to do. If it's not going to be here, that's cool. Let me look elsewhere. What other roles can I serve out there? And just don't be afraid.
Yeah. Michelle, I can't thank you enough for your time. What I'm finding, and this is kind of coming from therapists, from comments they're pouring in, is that really every single hospital, I think, is going to just be different. You have to know the culture of that hospital. There's a therapist who wrote in saying that length of stay is not a great argument that she can use, right? Because moms are already staying so short.
Sure.
And in certain cases, we're actually causing the length of stay to be a little bit longer because they're not ready to go home. And we've done the assessments to prove that. Like, we've done the evaluation, and the team is not that happy about that, right? Because they're hoping to turn over that bed a little bit faster. In those cases, it sounds like it's still persistence that's going to win, because you'll be able to use the readmission argument,
Mhm.
and likely in that case. When you
And
don't
with
have
anything,
evidence, what's
honestly, with
that?
anything, I was gonna say, I'm sorry to interrupt you, but with anything, how many times do we evaluate a patient that's bags are packed and they're ready to go out, and you're like, but their oxygen saturation 70. I'm sorry, I'm not clearing them. Yes, it's going to be uncomfortable and people aren't going to be super happy, but that doesn't mean that we don't do it. And I think that, being able to sit in that discord sometimes, knowing that you did the right thing and it's just uncomfortable, but you
What
did the
is it
right thing.
about this population? You know what? I'm thinking about that, and I'm just like, you were so right. Like, it's almost like I've had conversations. I'm telling you, Michelle, and I know that you probably have heard me say this before, but over the past 2 years, I almost feel like I've talked to really intelligent people whose brains turn off when it comes to the maternity unit. Like,
Yeah,
you're not going to you're not going to shorten that person's length of stay if their hemoglobin is down in the sevens. Like,
yeah,
no, you're gonna lengthen their length of stay, and you're gonna keep them in the hospital if you care,
yeah,
right? And we've
yeah,
had moms that have lost considerable amount of blood, and we have therapists who are tiptoeing around not wanting to say anything because they are afraid that their program efforts are gonna go out the window. No, you saved the mom. You
yeah.
saved the mom.
And I think that's where you really, as a leader, you have to always bring it back to the patient, no matter what. If you keep your focus on the patient, everything else can just go out the window, because I think there's so many different pressures that we all feel, and understandably so. We all have to be very aware, but at the end of the day, you can never go wrong with that. And I feel like so many folks, they get kind of conditioned by all of these pressures, and they lose track. And it always hurts my heart a little bit, because you really, we all got into this business, assuming that that was our loved one, and you would want somebody to advocate for your loved one. You wouldn't want them sent home early, and so I think really as leaders, I just plead with people, please, keep it very patient centered, because that really speaks to the therapist, and it really allows them to feel so supported in making these really tough decisions they're like the salmon swimming up the stream. Everybody else is telling you, got them out, get them out, get them out. It's like, but no, they are not ready, and it's okay. It's okay. You did the right thing. So
All
that's my
right.
soapbox.
I love it, Michelle. I have a pitch myself. I'm actually going to try to do it with you because
Okay.
I've been really nervous about it. But it's a hospital. It's like right in the same neighborhood of the hospital that we started these services for in Colorado Springs. This hospital is not providing these services, but I've actually been a doula at that hospital
Mhm.
and helped two patients, one after C-section elective. She chose it, and then one through a birth. And they both have like wonderful things to say. Especially the one after C-section, she brought me in as her physical therapist from the outside, and I saw her 24 hours after her surgery. And so, what I want to say to you, and this would be me coming to an outpatient. Or from an outpatient standpoint, to talk to the director of rehab. So, say I have your number, somehow we're able to connect, and I'm coming to you. And so, Michelle, I'm Rebecca Seagraves. I actually am a physical therapist here in town who worked at the hospital down the road and was really instrumental in bringing services, physical therapy services, specifically to moms after C-section. Had the honor of actually treating a mom in this hospital after C-section. She had just nothing but good things to say. And I really like to bring this idea to you about training staff who are interested in working on this unit to just help enhance recovery in this population. I know that there are some cases where moms don't feel like they've been seen or heard during their birth experience. CDC just put out research a year ago saying that 1 in 5 women experience some type of mistreatment at the time of their delivery. And I really feel like I have a solution for your team. Would you like to talk to me?
Mm, that's beautiful.
Would
Yeah.
you? I'm
Yes, of
almost,
course. Well, you know me, I'm a little biased, but yes.
you are biased. You are biased. But I
Yeah.
almost wonder, is that I'm not coming on too strong. I'm not even, saying what I'm going to do, but I almost wonder, is that too timid when I say for the therapist who would be interested in, because we have to be like honest, not all therapists are going to want to treat on this unit, right? And we
Right.
don't want to force them to.
Yeah. No, I think the only thing I would say that to add potentially would be maybe a little snippet of the cascade effect that is happening across the nation with other healthcare systems um, implementing postpartum care and seeing the positive effects of it, and maybe talking to that so that it also gave that side of it, that it is being done out there, not just from your experience, but really across the United States. That would be my only potential. But no, I don't think it was too strong at all. And I love how you um, talk to the patient not feeling heard in that specific thing. That resonated with me. And I can only say, because a lot of the feedback that we've received from the moms that have received our services, that's the first thing they say. I felt like no one was listening to me. You are the first person that made me feel like I was being heard. And that's something that I've kind of just taken note in my head. But there's so much truth to that. There's so much truth. And I think that's a beautiful point and so important.
Emphasize the moms who are heard, but then who are not heard.
Mm-hmm.
Those who are heard talk about those experiences, that
Yeah.
they felt heard when we were in the room, we were spending time. That's great advice. And yeah, you're right. We are tracking hospitals. We're now at 44 hospitals, at least from a survey, very low volume survey that we've just been putting out for hospitals, just to report, like, are you providing these these services, OT and PT on the maternity unit after birth? And right now we've collected information or feedback from 44 hospitals. We're hoping really to double that number. I mean, honestly, by next year would be like a lot, but I think it's more of they're out there, but we just don't know that they're out there. And so if you're watching this later and you want to, put your hospital on the map, please do follow us at Pelvic Health Network. We have a directory of hospitals that you can go on the website, add your information, and just let people know where to find you. They would want to. There was a comment, I think, from Dr. Catherine Sylvester, who is joining us tonight. She would want to be at a hospital that prioritized her health. And that's really powerful. Dr. Josie Jarvis, she's a doctor of occupational therapy and brilliant. I'm actually speaking with her at the AOTA Women's Specialty Conference. They're putting this on this year, and that's really exciting. I think that kind of just minds like that are really important to just highlight that there's a team of us really that's putting this out there. Is that right, Michelle? You worked with an occupational therapist in your hospital to institute these services. Is that right?
Yeah. Yep. It was occupational therapy. And then we began at other hospitals with staffing. They may not have had somebody who was interested who was occupational therapist. So physical therapy certainly stepped in. But yeah, for us, they paved the way.
Occupational therapist. I have to say, I mean, and Dr. Sylvester, I've told her, I said, when you said this, I'm going to steal it forever. But, to deny patients both, it really, it calls for an incomplete patient experience, right? Both occupational and physical therapy are needed in so many other patient cases. We see them together after knee replacement. If we're trying to send them home same day, we're seeing them in trauma cases. If someone was admitted to the ICU because of a hypertensive disorder or a brain bleed after birth, hopefully OTs and PTs would be tag teaming and seeing that person. So I really think that she's right. It makes for an incomplete patient experience when we deny them both disciplines.
That's beautiful. Yeah, that's very wise and very true.
All right, Michelle. So, what's in the future? If you had a program, 30 seconds, take it away. If you had a program that you could develop and you can put your stamp on it and say, wow, you did this really great thing. I'm thinking early mobility ICU, all of those kind of great things that we've seen in our history. What would it be? Go.
Oh my gosh. I think for me, my best ideas come from my frontline staff. So for me to think of something, my goodness, that's pressure. But if I had to, I'm now dabbling in the inpatient rehab world. So anything inpatient rehab, I am all in. Like, I'm ready. Let's go. I want to see some programs there. I just got to figure it out yet.
Oh, I love that. I have to just say this honestly as we close. I would have loved to have a manager, a director of rehab like you to work for. I mean, this has been a blast just knowing you, getting to know you, working with you and your team over the past few months. But I'm telling you, as your employee, I feel like I could fly. I really
Oh
do.
my gosh. Well, that means more than you could ever know. I think the world of you. You're amazing at what you're doing. And it's my honor to be in your presence, to be honest with you.
Excellent. All right, Michelle. Well, we'll keep in touch. Thank you so much for your time. Really.
Yeah. Thank you all.